The 5-4-3-2-1 method is a grounding exercise that can help you stay in the moment and avoid negative thinking and worry. You can do this exercise anywhere, at home, at school, in the car, or even in the middle of a crowd. You can do it sitting, standing, or laying down. Counting down from 5, use your senses to list things around you. Make an effort to notice details about these things. This is how to do it. Start by breathing deeply in through your nose and out through your mouth. Then slowly look at your surroundings. Find 5 things that you can see around you. Maybe you see a colorful poster on the wall, the spider web on the bookshelf, the lamp on the nightstand with the red shade, the cat sleeping peacefully on the chair, the cactus on the dresser that has finally bloomed. Then list 4 things that you can touch. The warm mug in your hands, the soft comforter on the bed, the denim of your jeans, the scratchy carpet under your feet. Next, listen for 3 things you can hear. Maybe the ticking of a clock, the quiet hum of your computer, the sound of traffic from outside. Now try to find 2 things that you can smell. The tea in your mug, the clean scent of your clothes. Finally, list 1 emotion that you feel. This is a way to ground yourself so you can feel present in the moment and in control of your surroundings. Now you try. Use this method when you feel overwhelmed to bring yourself back to the present moment.
To everyone. Hi.
Good afternoon.
Good
Hi,
afternoon. Very good. So Hafiz, you're on? Right. So
Okay.
you're up to startup.
All right, welcome to Family TV in Trinidad. My name is FISCAL and I'll be your main host this evening. May the peace and blessings of God be with all who are joining us this evening. And just to tell you about Family TV, Family TV is a subsidiary of FISCAL, which is a non-profit organization registered, and the sister organization of the National Islamic Counseling Services. Family TV's main programming objective is to propagate and rejuvenate good family life. We focus on parenting, marriage, and all aspects of improving family relationships. FISCAL has partnered with the U.S. Embassy in Trinidad Public Affairs Department to conduct a 4-part series on mental health. Yes, a 4-part series. We have also received approval from the Chief Education Officer, Mrs. Lisa Henry David, for all teachers to participate in this program. She also communicated this to the school supervisors, principals, vice principals, and teachers. We would like to say officially, thank you to Mrs. Henry David and Mrs. Michelle Carter, who was instrumental in getting the whole process approved. And at the same time, I would like to say welcome to all teachers and parents joining us who were also notified by the respective vice principals, and teachers. The first part, as I indicated, 4 parts, the introduction to mental health, was done last week. And we defined general health, physical health, spiritual health, and mental health. We debunked the myths of mental health, which a lot abound in the community. We examined the stigma that scares people away from seeking help for mental illness. And for those who missed that program last week, you can go to Family TV on Facebook page and see the episode, or if you would like to clarify any issue discussed. Our second program, entitled Building the Foundation for a Great Family, which is today. We would focus on the common mental health issues that affect children 1 to 11 years, and that will cover all aspects of it. The third episode, Preparing Our Youth for a Real World, would be aired on the 25th of April, which is next week. And that would cover the common mental health issues that affect teenagers from 12 to 18. And also building relationships. And we'll probably start to touch on some areas of mental health for adults and the elderly. The fourth program, Mental Health for All, would be held on May the 2nd. And that would complete the mental health areas for adult and the elderly. We look at preventative factors generally, and access and support systems also generally. And then we will give additional information that our professionals feel that is necessary to deal with this issue. Your input via questions, comments, and even contributions are welcome. You can do so via WhatsApp using 868-763-2960 or 868-389-6006. You can also check our website, islamkt.org. If based on questions and comments that we realize that we probably need to have additional programs to cover additional topics that was asked, we would certainly arrange additional programs. As a precursor to today's program, I would like to just quote briefly from an article entitled Coronavirus 2019 and Mental Health for Children and Adolescents, written by Dr. Ezra Goldstein, PhD at the University of Minnesota in Health Services in conjunction with Hefei Wen, also PhD in Health Services Research and Health Policy, and Dr. Benjamin Miller has a doctorate in psychology. And I quote, "Children and adolescents are generally healthy and do not require much health care outside of regular checkups and immunization. However, mental health care is very important for children and adolescents. Most mental health disorders begin in childhood, making it essential that mental health needs are identified early and treated during this sensitive time in child development. If untreated, mental health problems can lead to many negative health and social outcomes. The COVID-19 pandemic may worsen existing mental health problems and lead to more cases among children and adolescents because of the unique combination of the public health crisis. Social isolation and economic recession, economic downturns are associated with increased mental health problems for youth that may be affected by the ways that economic downturns affect adult unemployment, adult mental health, and child maltreatment. And I note child maltreatment. Educators, administrators, and policymakers must minimize the disruption that school closures will have on academic development. Schools offer many critical services to students outside of education. For example, schools are a major source of nutrition for many students, and ensuring food security has been a common component of school closure plans. However, other services are equally essential to children's health and must be addressed. And I think this in a nutshell gives us an indication that it applies to Trinidad also. And that question of school nutrition that we have, that plays a big part in our education process and is now almost non-existent, we need to cater for that also, and how it affects the mental health of the children. The panel for each program would include professionals specific to the different areas that we will be dealing with. We have a great panel of professionals today for today's program. I would like to first introduce my co-host who would introduce the panel. She is a counselor herself and trauma therapist and has been with NICS from its inception. Mrs. Michelle Bayam. Michelle, go ahead, Michelle.
All right, yes. Good afternoon, pleasant good afternoon to our panelists, you the viewer, and of course to NICS admin and Hafiz, you yourself. And I'm really, really happy to be a part of the program. As Hafiz has mentioned, I've been with NICS since inception in different capacities, and it's always a pleasure to assist in our focus, which is to educate you, the viewer, so that you can better build your family, you know, and even the goal in this program is no different. As Hafiz had mentioned, you know, building that firm foundation, which we believe mental health plays a big role in keeping families stable. So if we share the information that you can use, you know, it will help you to stabilize the foundation of your families. So it's always a pleasure for us to present to you. So today I want to introduce our panelists, very esteemed colleagues, and we're very proud of them. We are proud of their achievements and the varied accomplishments of each. So I'll begin with Mr. Akeem Modest James. Mr. James, a psychiatric social worker with a Master of Social Work specializing in advanced interventions from the University of the West Indies, St. Augustine, and also holding a Bachelor of Science degree in Social Work honors from UWI, Cave Hill campus, Barbados. He has over 3 years experience in the field of mental health and domestic violence. He also serves as an instructor at University of the West Indies, teaching in the field of social work, and is attached to the Life Empowerment Center of Trinidad and Tobago, providing mental health services. Mr. James considers himself a scholar practitioner, intensively engaged in fighting the stigma of mental health, and is always eager to share his experiences within the field of social work. He has also co-authored and published 2 journal articles entitled, firstly, Primary Care Physicians, Identifying Abuse of Older Adults in the Small Island State of Trinidad and Tobago, published in the Journal of Adult Protection, and secondly, Mothers' Physical and Mental Health Status After Homicide of Their Adult Children in the Small Island State of Trinidad and Tobago, published in Journal of Traumatology. 2 very, very pertinent topics. So I'll just hand over to you, Akeem, to just say a little thing on your own behalf. Share with us, let us hear your voice a little bit, and then I'll introduce the other panelists, and you all will do the same. So after I introduce you, say a little couple lines on yourself.
Okay, thank you so much, Michelle, and thank you so much for inviting me to be on this panel discussion. As Michelle said, my name is Akeem Modest James. I'm a psychiatric social worker. I love to educate people and bring awareness to mental health. So that's why when Michelle had asked me to be on this panel, I quickly said yes without thinking twice. Because I find that a lot of people have myths towards mental health and they just associate it with, you have to look a particular way, react a particular way, and they don't know the other aspects of it. So that's why I decided that I need to be here to educate or to help bring some type of awareness to families, especially because the family has been deteriorating over the past couple of years. So we have to really reunite families. And I guess when we have a child, because this topic today is on children, it kind of puts a strain on the family. So we are here to bring some sort of intervention in regards to that. Thank you so much.
Excellent, Akeem. Thank you. Spot on. Okay, so our second panelist, Swain Leo Hussein Cadogan. A Trinidad and Tobago citizen, Swain Leo Hussein Cadogan holds both Masters of Sciences and also a Bachelor of Science, both honors, in forensic psychology from Teesside University, Middlesbrough, England. Mr. Hussein Cadogan is currently employed as a forensic psychologist at St. Anne's Hospital via the Northwest Regional Health Authority. He also serves as a consultant for Integral Purist Limited, a private mental health care company. His current areas of expertise include forensic psychological evaluations and behavioral risk assessment to determine likelihood of violence and criminal recidivism. Mr. Hussein Cadogan's interest in forensic psychology stem from a family member being murdered. Mr. Hussein Cadogan is currently in the final stages of qualifying as a field traumatologist and certified trainer with the aim of becoming a certified traumatologist and eventually master traumatologist with the Green Cross of Trinidad and Tobago. So I introduce to you Mr. Swain Leo Hussein Cadogan. Couple words, Leo.
Good afternoon, all. Thank you, Michelle. Thank you, panel, for inviting me. Yes, the name is a bit long. It is a mouthful. So I suppose for the duration of this session, everyone shall refer to me as Leo, short and to the point. As stated, I do work as a forensic psychologist with the Northwest Regional Health Authority. In that regard, part and parcel of my duties involve the assessments of individuals who have matters before the courts. And there is some query as to their mental health status. Programs like this one are invaluable. As Mr. Modest James mentioned, the family unit has been slowly unraveling within the past decade or so. And now within my profession, if we can arrest, or I should say, if we can tackle mental health issues from a young age, then chances are it would not spiral out of control to the point where I have to get involved later down the line when, the legal services have to step in. And so that is why I'm quite happy to be a part of this panel this afternoon. Thank you. Thank
you, Leo, and we're certainly happy to have you. Our third panelist, Mr. Ali Mohammed Baksh Jr. He graduated from the University of the West Indies as well. We have a lot of UWI graduates, excellent, St. Augustine in 2015 with a first-class Bachelor's of Science in Psychology major and Sociology, Anthropology as a minor. He then obtained his Master's of Sciences in Clinical Psychology. He is currently a clinical psychologist and phlebotomist. As I said, we have an interesting panel, interesting accomplishments, with a PhD in clinical neuropsychology, pending, and a DBA in business administration also pending. Ali Mohammed Bax Jr. is the author, another author, behind the books Uncovering the Unconscious and secondly, My Mind, My Illness. He has great interest in phobias, particularly social and specific phobias, as well as a personal interest in diabetes in honor of the memory of his late mother. He works with children through psychoeducational assessments in addition to working with adults mostly through therapy. He's a member of many groups, including the Association of Psychiatrists of Trinidad and Tobago, Trinidad and Tobago Association of Psychologists, American Diabetes Association, and British Psychological Society. In his spare time, he writes articles for the newspapers, has a passion for theater, and enjoys learning new languages, particularly Italian, Spanish, and German. He is an animal lover with a great appreciation for nature. Excellent portfolio, sir. Welcome.
All right. Good afternoon, everyone. You all can hear me, right? Yeah. Okay. So thanks for having me here today. Thanks for the invitation. We realize that in this country and in the world by extension, there's a lot of children that are going misdiagnosed or overly diagnosed. Furthermore, we are living in a society where there's still a lot of stigma attached to the whole concept of mental health. And I am glad to be here today to educate as much as I possibly can with regards to particularly disorders that children face, and to educate parents and teachers as well, you know, with the symptomology of these different disorders. Because you realize now a simple thing like, okay, he's crying, he's probably depressed, is putting far more greater judgment and stigma on a child who may not be depressed. You know, so it's good to be here to try to clarify some of the disorders as well as the symptoms and the causes that are behind these disorders. Thank you.
Excellent, thank you. And we're certainly looking forward to that. Thank you. Our final panelist for today is Mrs., the lady on the panel, Vandana Susanka Ali, clinical psychologist. Ms. Susanka Ali holds a Master's of Sciences honors degree from the University of the West Indies, St. Augustine. You guys make our university proud. Okay. She works in the field of child protection and has played an instrumental role in re-engineering the current child protection system into a new and progressive one. She has operationalized and manages assessment centers in Trinidad and Tobago. Mrs. Susanka Ali has worked with very young children with basic adjustment issues all the way to late adolescent juvenile offenders with severe clinical problems. She has also done numerous presentations on child protection, child development, children's rights, parenting, self-psychology, marriage, and relationships. She is no stranger to FISCAL either, in providing her presentation skills and offering her counseling skills where necessary. Welcome, Mrs. Susanka Ali.
Thank you very much, Michelle, and good afternoon to all of our viewers. Like my colleagues, it is indeed a pleasure to be on this panel to discuss these very important issues. And, you know, just following on from Leo's words, I feel very passionate about being part of a discussion like this because of the state of our country. And I feel that the only way to be able to intervene and to stem the tide and to sort of turn things around a bit is to start from changing things from children. You know, if we intervene early enough and we're able to understand, you know, what children are faced with, to be able to provide the necessary interventions and information for parents as well and teachers to be able to target the way they treat with children's issues, I feel like we have a better chance at managing the situation in the future. So that's my goal, to be here today to be able to address some of those. And I look forward to the discussion at hand.
Thank you. So a very warm welcome and appreciation to our panelists for being with us on this journey. So I'll hand back over to Hafiz and we shall begin.
Okay. So very impressive panels. And I again would like to welcome them and thank them for accepting our invitation to join us in this noble event here. I just want to verify everybody is hearing me. Just raise your hand. All right. Okay, so I think we should first start with mental health covers a very broad spectrum. Could someone describe what you would consider to be mental ill health generally? Or should I call on somebody? Okay, let's start with the lady that we have on the panel. Vandana?
Okay, sure. I think it's important to understand what is mental health, right? And mental health is the state of our cognition, our brain, how we feel, our thoughts or feelings or behavior. So when we talk about mental ill health, it's anything that significantly impairs our functioning in those areas. Now, there's a difference between, your general mental health problems and mental illness, right? So you may have a mental health challenge or mental health problem, which may be temporary, it may be transient, you may be going through some difficulty, and that causes you to feel some level of depression, and I'm using the words very carefully, because it may really be, sadness. You may feel anxious about things. It may affect you in terms of how you perform in different areas of your life briefly, but then you are able to move along. And that is very different from mental illness, which creates a significant impairment in the way you're able to function in your everyday life.
All right. And Ali, could you help us with this next question? What is a mental disorder? What are the main categories of disorders experienced by children?
Okay, so basically mental disorders are conditions that affect the way we act, the way we think, the way we feel. These now will then determine how we are able to relate to others, how we are able to deal with stress or stressful situations. And it also helps us with how we are able to be in social situations. Now, for children between the ages of 1 to 11, which we are primarily dealing with today, the main disorders or the category of disorders you will find are the one called the neurodevelopmental disorders. So these are things like intellectual disability, autism spectrum disorder, ADHD, specific learning disorder. You have the communication disorders, such as language disorder, speech sound disorder. You have childhood onset fluency disorder, also known as stuttering. You have the motor disorders. So motor disorders such as developmental coordination delay or simple like stereotypic movement disorder. If you have to move away now from the neurodevelopmental disorder, because we are realizing that quite a lot of children are actually being diagnosed with depression in this country. So we have things like disruptive mood dysregulation disorder. We have major depressive disorder. And we have the one that is prolonged to the point that it becomes persistent depressive disorder. We also have a lot of children who have anxiety disorders, and it stems from separation anxiety disorder, generalized anxiety, panic disorder. We have specific phobias, social anxiety disorder, or selective mutism. If we have to go even further, we are seeing children who are suffering from eating disorders. So those with anorexia or bulimia, binge eating. And then finally, we are seeing those with the impulsive disorders. So conduct disorder or oppositional defiance. I also forgot PTSD and acute stress disorder, just to name a few.
Wow, that's excellent. Thanks for outlining the categories. A bit later, we'll select like the main ones and go a little more in depth so that we can share with the viewer the signs and symptoms they could look for, yeah? Now,
Okay.
one of the things that came out is that word disorder. And I wanted to just impress upon the viewer that disorder, what does disorder really speak to in terms of, we use it a lot, but what does that mean so that they can understand? There is the condition, and then there's the disorder, meaning it has become a disorder. What brings it to a disorder? What causes it to be called? Yeah.
Right. So, like I said earlier, right? You can't just watch a child who's crying and say this child is depressed. To give a diagnosis of major depressive disorder goes far more than a child just crying. There are certain symptoms that a child or an adult have to meet, a criteria. But aside from the mere symptoms, there is a time period in which that these children or adults have to meet this disorder. So very briefly, major depressive disorder, right? The time frame for it is a period of 2 weeks or more. A disorder like persistent depressive disorder, for children in particular, the time frame is 1 year or more, while for adults it will be 2 years or more.
Okay, and this is what I wanted to, not to interrupt, this is what I wanted to bring out just briefly, because we could get into that in the other question, right? So it's the time factor and the functioning factor, and that's what I wanted the viewer to grasp. So when something has become a disorder, it's about a time factor and a functioning factor to the point where it has prevented you from your daily routine and function.
Right, so it causes somewhat clinically significant impairments.
Right.
So for the neurodevelopmental disorders, they stress specifically that these disorders must occur during the onset of the developmental period of a child.
Yes, correct. And then we could go straight into disability. What does that term mean in terms of mental disorders? The viewer will know about it in a physical aspect. Everybody can quickly figure out what a physical disability is. But what does disability refer to when we're talking about mental disorders, mental health?
So the disability in itself is when the disorder in itself becomes long-term or has a long-term impact on an individual's normal day-to-day functioning. So we're looking at a period, let's say, of 1 year or more. Once this disorder prolongs to the point where it affects significantly the person's day-to-day activities, it becomes a disability.
Excellent. Thank you, Mr. Baksh. Back over to you, Hafiz. Maybe we could just go straight into, okay, so let me put the other question out. Hafiz, are you there?
No, you go ahead. You're doing well.
Okay, all right, cool. So let's look at another question. What can a family member see? So we're looking at children, right? What can they see that would give the first clue that, something is wrong? There's a mental health challenge that we're facing. They may not be able to categorize it as that just yet. But when we're looking at young children, what is one of the first things that we can tell the viewer, when you see this or when you see that, start to observe a little bit further. Vandana, Leo, anybody?
Start off. I'm sure my colleagues will pick up as well. But the thing about mental health, mental illness, is that unlike physical health, it is not visible, right? So just to debunk any myths that might exist out there that we think people with a mental illness or mental disorder looks a particular way, that is not the case, all right? And particularly with children whose development is evolving as well. Things may look one way in this period of time and then look a different way at another time. So I just want to start there. The other thing is that it's very important to know your normal functioning of your child, right? And I use normal in quotation marks as everybody's normal is different as well. But you know what if you have a very active child and suddenly your child becomes very withdrawn, or you're familiar with your child's sleeping pattern and you find that your child suddenly has insomnia or is sleeping too much. You know, you have a child who is usually very active and socially interactive, and suddenly that child's behavior has changed. So I would say one of the key telltale signs is really looking for changes in normal behavior and functioning of your child.
Okay, yeah. And that brings out the whole aspect of the baseline. As I would speak to a lot of parents saying, okay, you need to understand what the baseline, what the normal behaviors of your child would incorporate, so that then you can observe the difference. Yeah, so not as soon as you see something and say, okay, something is wrong. So it's really about, we're trying to educate you to have a consistent observation pattern, so that when something goes different outside of that, then you can begin to become more alert. Okay, excellent. Thank you. Thank you, Vandana. Very good. So what is usually then the earliest mental disorder? Mr. Baksh outlined quite a few, which was a very comprehensive list. What is the earliest one of them that can manifest in the children? Like, you know, so if a parent is, we're teaching them to become more vigilant, more observant, what is one of the earliest that it can possibly be in terms of the incidents? And that can be back to Mr. Batch, or who want to take this one? Mr. Batch, thank you.
What I realized with this question is, with my interaction in different countries, right? You see different disorders at different ages. Now, primarily here, you would see children being diagnosed with, let's say, ADHD or major depressive disorder from a very early age. But let's look at the DSM, for example, which pretty certain all of us are familiar with. One of the earliest disorders that you will see, one of the first neurodevelopmental disorders, is one we know as global developmental delay. Mm-hmm. Now, the criteria for this is you have to diagnose this before the age of 5, because this is where a child fails to meet their developmental milestones at the age in which a child would normally meet developmental milestones. So for here in this country, from what I have seen from my experience, and it could be different from others, definitely things along the neurodevelopmental spectrum, particularly ADHD, as well as the mood disorder, particularly major depressive disorder, as well as anxiety as well.
Mm-hmm. Okay, excellent. Thank you. Thank you for that. Okay, so you just mentioned about, anyway, we'll come back to that as you go through. I'm sure you'll come across it again. So now we want to get into the outlining of signs and symptoms of the most common ones. So what we're trying to do, time permitting, is to really give the viewer a more, slightly more in-depth ability to look for themselves and see if they can figure out what they're seeing. Yeah. So that would be for the parents, caregivers, siblings, whoever. So if we share it across the panel, maybe Leo, you can jump in here as well. When we choose the disorder, signs, symptoms, and I wanted risk factors as well included. Risk factors being not only being born with the condition, but what in the environment can contribute. And when we say risk factors, we're talking about those things that can come together to increase the possibility of the child having that disorder, right, or developing. So I'll hand it over to you. Who's going to start? Mr. Baksh, as you are on it already, and then we'll go between Vandana and Leo. You can jump in as well. Okay? Most common signs, symptoms, risk factors.
All right,
Thank you.
Yes. So I'll start with the...
Just before we go into it, I just wanted to tie it back to the question you asked me earlier about how parents can, recognize the early signs. Mm-hmm. And so this discussion here is going to be very critical for that, because once we understand what are the signs and symptoms, those are some of the things that parents can look for. But I just want to also kind of put a cautionary statement, and I'm sure my colleagues could relate to this We all have lay psychologists and out there, and I don't want I don't want people to understand. Okay, now we understand signs and symptoms, and from the time you start to see one or two of those, you start diagnosing your children like that, right? So just to kind of understand, as we go through these signs and symptoms, it is not just the presence of one or two of these that would mean that, you know, your child has these things. Of course, we will go through the number and the criteria to meet, but it's usually a constellation, a combination of several symptoms that come together and also impact your functioning to really paint a holistic picture. So just wanted to put that out there. So I don't want anybody panicking or viewers panicking as they hear the signs and symptoms and they're like, oh my gosh, yeah, my child has this, my child has that.
Yes, thank you, Vandana, for that. And over time with baseline as well. Over time, knowing the baseline, meaning knowing the child's normal behavior as well. So we're keeping all that in mind, and thanks for the question. And really and truly, I mean, a lot of it already going on the internet, you know, a lot of diagnosing going on the internet. But we just want to equip you. And remember, the goal is for you to be educated enough to take action. And that action would be to go and seek professional intervention. Yeah, so we're not asking you to diagnose and begin treating on your own.
Michelle, okay. if you don't mind me jumping in here.
Yes, please.
One thing I would like to say is that when the psychologists give the signs and symptoms, what parents can do is make have like a little notebook to just document some of the changes that they would have observed from their child's behavior. So if this child was outgoing and all of a sudden is withdraw, doesn't want to do any task, anything, they can make little notes in their notebook so that when they come to a healthcare provider, they can give an accurate history, which is extremely important. Oftentimes you ask parents questions and they are not sure. So the child is exhibiting these behaviors, but when you ask, how long did this start? I can't remember, I'm not too sure, that's how he is. So for parents, what you can do is just, you know, make a little note, have a little notebook to document some of the changes of behaviors that you would have noticed. So that gives the healthcare professional a great help.
Yes, a good history is really important. Thanks, Akeem. All right, so we're ready to begin. So over to you, Mr. Baksh.
Okay, so again, before I start as well, right? This age 1 to 11, I know we are talking primarily or specifically to the parents, but at this age, a child spends a lot of time in the school. So this as well is very particular directed towards teachers, right? The symptoms and the signs, you all as well have to pay close attention because a lot of referrals I get, the first thing that the parent will say is, well, the teacher noticed this and the teacher noticed that.
Right.
And you know, the parent was not even aware of some of the symptoms that a child may be showing. Similarly, a child may react and behave differently in school as opposed to at home. So all of this now is directed specifically, yes, to the parents, but as well to the teachers.
Nice.
So I'll start with the neurodevelopmental disorders. And the first and foremost one we are looking at is intellectual disability. So intellectual disability is where a child has deficits in their intellectual functioning as well as their adaptive functioning across a conceptual, social, and practical domain. Now, when I say intellectual deficits, I'm talking primarily about problem solving, planning, judgment, reasoning, abstract thinking. These are the deficits that you will see coming out of intellectual functioning. When I talk about adaptive behavior or adaptive functioning, I'm talking about how are they functioning at school, how are they functioning at home, their ability to take care of themselves through proper hygiene, or their ability to do chores at home, or to follow simple instructions in school. So these primarily are the two main symptoms or criteria when it comes to diagnosing intellectual disability. Now, across the spectrum, to make it easier on time, all neurodevelopmental disorders must occur during the onset of the developmental period. So this will be another symptom or criteria for all of the disorders across the neurodevelopmental. Intellectual disability has 4 levels. You have the mild, you have the moderate, you have the severe, and you have the profound. To diagnose intellectual disability, a child has to be assessed. So you can't just look at a child's grade in school and see F term 1, C term 2, D term 3, and then think, okay, well, this child has intellectual disability. Let the professional first and foremost assess the child thoroughly, because like I said, it goes far more than just intellectual functioning. It has that adaptive functioning part of it as well. So that's intellectual disability. 2 other disorders that stem from intellectual disability is the first one I mentioned before, global developmental delay. And this is a disorder that's diagnosed before the age of 5. Children who fail to meet their developmental milestones at the age in which a child would normally or supposed to meet developmental milestones. The third one is unspecified intellectual disability. And this is given for children over the age of 5 who would be unable to be assessed due to a sensory deficit. So children who may be blind, who may be deaf, or who may have locomotor difficulties, right?
Locomotor. To explain to the viewer a little bit more about locomotor.
More so,
what are they seeing? Awkwardness, what?
Physical impairments. And I will talk more about a disorder called developmental coordination delay in a while. Okay. So moving along from the intellectual disabilities, we have now the communication disorders. The first communication disorder we will look at is one called language disorder. Language disorder is persistent difficulties in the acquisition and use of language across modalities. And by modalities, I mean spoken, written, or sign language. Right? This stems from difficulties in comprehension and in production. And there's 3 criteria. 1, where the child will have a reduced vocabulary. 2, where they have limited sentence structure. And 3, where there is impairments in discourse. Now, again, it must occur during the developmental period. So that's the whole idea of language.
Sorry to interrupt you, right? Impairment in discourse, you're talking about the words not flowing out properly.
Yeah.
But yeah. So just to make sure that the viewer understands, yeah. Go ahead,
Okay.
Sorry to interrupt.
So the second one is speech sound disorder. So in a nutshell, it's basically a disorder that looks at difficulties in speech sound production. The third disorder is childhood onset fluency disorder. And in a broad nutshell, this is the stuttering disorder. So children who stutter and who would have significant clinical impairments due to their stuttering. So children who may not be able to speak or perform properly in school, who would not be able to speak properly in their social setting because of their stuttering issue. The other one is a social pragmatic communication disorder. This is where there is persistent difficulties in the social uses of verbal and nonverbal communication. And all of the following must be met to give a diagnosis of social pragmatic communication disorder. So the first one is children who are not able to understand that which is not explicitly stated in communication. Children who do not follow or understand the rules and regulations for conversation, for storytelling, and for communication. Children who do not know how to use communication or language for social purposes. And children who do not understand how to match communication for the current topic at hand. So these 4 criteria are what makes up social pragmatic communication disorder. Moving away from the communication disorders, we have now autism spectrum disorder. Now, autism spectrum is where you have persistent difficulties in social communication and social interaction across multiple contexts. So let's call this, what I just said, criteria A. criteria A has 3 parts to it. The first one is difficulties in non-verbal communicative behavior. The second one is that they don't have any need to understand, to develop, or to maintain relationships. And there is difficulty between social and emotional reciprocity. So these are the 3 criteria for part A. Part B looks at a pattern of repetitive behavior. And there are 4 parts to this. And a child must need 2 or more of the 4. So the first one is that fixated interest. So children who have an interest, but it's fixated on certain things that will give them interest. They also have a desire for sameness.
Ali, before you go on, in the interest of we have a wide cross-section of viewers, and to make it understandable to them, you could give a actual example when you explain what it is. Give an example of the behavior, so it'd be easier for to make sure that the audience understand specifically, because there are a lot of different things that could be similar.
Okay. All right. So like for the whole idea of autism spectrum, these are children, let's say in the school setting, who will have no desire to have friends, no desire to understand what it is to have friends or to keep any sort of relationships in the school. They are the children who prefer sameness, order. So if they have, let's say, this simple piece of paper here, right? They have a fixed interest in this piece of paper, that anywhere they go and anything they do, they always have this piece of paper with them. These are also the children who they have hyper or hyposensitivity to sensory input. So it's too bright, or the noise around them, it cringes them basically. They don't like noises, loud noises, or bright sounds. Brightness. They don't like brightness, right? These are the sensory inputs that you would look for, or children with autism will display, right? Of course, all of these symptoms, again, they cause clinical significant impairment in the child, in their home life, and in their school life. Another disorder we could look at is...
Yeah, just let me...
I'm not hearing.
Unmute your mic, Michelle.
Right. So, yeah, just to interrupt you again, as you talked about significant impairment in home life and school life, right? Now, remember, the program is really focused on that. So we're given information so that we could figure out the disruptions, yeah, especially in the early years, the foundation years. So when we say significant impairment to home life and school life, can you give us some idea in terms of what are these?
So basically, like the symptoms that I spoke about just now, you will notice the behaviors in this child goes from what you would normally see this child behaving to somebody who is displaying a different behavior altogether. Or also, this child has this disorder all along, and these are the normal behaviors that they are displaying. Right. So when I say it causes clinically significant impairment, you're looking specifically at the symptoms that may or may not cause the distress in the child. For example, when I say hyper or hypersensitivity, hyperactivity to sensory inputs, I'm talking about these are children, if they don't like bright areas, would try to avoid bright areas altogether. If they don't like loud sounds, they would try to avoid it altogether. So let's say the whole family is in the living room and they're looking at the television, and this child does not like the loud sounds. They would try to avoid that altogether. So you would now find this child being in his room, more fixated with his interests and the sameness that he has, right? So these are the things that you would more or less look for.
Yes, and you find sometimes that now the whole family life is circled around the peculiar behaviors being exhibited.
So there's a
Correct.
whole adjustment that now needs to be done.
Okay, wonderful. Okay, can we give you you want to take a break and we switch to, or you're good?
I could do one more neurodevelopmental
Right.
and then I could take a break. Yeah, sure.
Yeah, okay,
So,
good.
another one that we look at is one called specific learning disorder. Specific learning disorder are difficulties in learning or using academic skills. Now, for children, there are 3 types of specific learning disorder. There are the ones with impairments in reading, ones with impairments in written expression, and ones with impairments in mathematics. Of course, a child could have all 3, they could have 2, they could have 1. But to diagnose specific learning disorder, of course, the child has to be assessed. But the criteria are as follows. So they need to have one of the following 6 criteria within a 6-month or more period. So here's where you're looking at a time frame, a disorder with a time frame, right? So the first one we're looking at is children who has slow, effortful word reading. The second one is children who have difficulties in understanding what was read or what they read. The third one is difficulties with spelling. The fourth one is difficulties with written expression. The fifth one is difficulty with number sense. And the sixth one is difficulties with mathematical reasoning. So out of these 6 criteria, once a child is assessed and they have one or more of those 6 criteria, and it has been for a period of 6 months or more, then we could look at a diagnosis of specific learning disorder. And then furthermore, with what impairment? Is it with reading? Is it with written expression? Or is it with mathematics?
Right.
Going back to the autism that I just made mention of, I also failed to mention that autism could also be comorbid with intellectual impairments, with language impairments, with a genetic component, or with another neurodevelopmental disorder.
Okay, and comorbid means that it's existing with another disorder, which is what Mr. Bax was calling out. So you have that and something else, and it's really about determining, the way forward and with that. Okay, excellent. Thank you. That was well outlined. All right, so who next? Vandana, could you tell us about some, maybe you can choose in your experience what is common and just briefly go through. I know phobias is something we want to really touch on as well. I don't know between both of you who would do that. Maybe we could switch back to Mr. Batch then.
Josh has a special interest in phobias, I believe he mentioned.
Yes.
So I might leave that one off. But just to talk a little bit about ADHD, did we talk about that one as yet?
Not in detail, not going into any.
So the thing with ADHD is that this is one of the very, very common diagnoses that children tend to be misdiagnosed quite early with as well. But essentially, ADHD is attention deficit hyperactivity disorder, and it requires a certain number of symptoms of inattention, as well as hyperactivity and impulsivity that must have persisted over a period of time, and it must be inconsistent with the developmental level of the child and negatively impacting their ability to function socially, academically, and so. It must be present before the age of 12 and be present in more than one setting. So you would find that you may notice the symptoms of ADHD at home, as well as in school, or with friends, as well as with relatives. And there must be clear evidence that the symptoms are negatively impacting the child's ability to function in these settings, right? Now, what are some of those symptoms that people can look out for? So in terms of inattention, you might find that, and remember, children's attention span may typically be short as well, right? So you're looking for what is really abnormal in the setting. So you're seeing a child, for example, who has difficulty paying attention, sustaining their attention in the classroom, for example, or you give them a task and they can't stay on task for very long, sufficiently to complete that task. They don't seem to listen when spoken to directly, and this is not your usual defiance that may present in childhood. They may fail to follow through on tasks. They may make a lot of careless mistakes, be easily distracted, very forgetful in their daily activities. And then when you look at the hyperactivity, impulsivity side of things, you find that this is a child who can't sit still, right? There's a child who's fidgeting all the time, tapping their hands, squirming in their seat. You know, we have like little ones who, you know, you put them to sit and then they're on the table, they get up, they walk around the room, they slide on the chair, you know, they leave their seat a lot, very, very, very restless. If they have an impulse to do something, they can't stop themselves from doing it. They must do it. You know, they may blurt out answers quickly when they ask, talk excessively, can't wait their turn, those types of things. Right. All right, so these symptoms must occur quite often, and as I mentioned, in more than one setting, and be impacting the child negatively in terms of their ability to function. Depressive disorders, I think I want to spend some time on that because that's very, very common. And, you know, it's something that I think sometimes in our society, we tend to underestimate in children, this in the general public. You know, you have the idea that what children have to feel depressed about. You know, they have life happy, you know, there are no worries. Why they have to be worried about or depressed about anything? I'll give them something to be sad about, you know, to cry about.
Correct.
That's the society we live in. But it's a very real thing. And depression is not just present in adults, it's also present in children. And one of the main subsets of the depressive disorders in children is major depressive disorder. All right, so we started to talk about it earlier. It's a condition that must exist for at least 2 weeks. And some of the symptoms of childhood depression include again, changes from normal pattern of behavior, right? So we're seeing a child has lost interest in the things that they typically would enjoy. Their grades might be declining. They're withdrawing from family and friends. They may be having problems with sleep, either sleeping too much or sleeping too little. Similarly, eating too much or eating too little. You're seeing weight changes as well. Unexplained crying. You may have children, even as young as under 11, having thoughts and actions of self-harm and suicidal thoughts and intent as well. There's also persistent depressive disorder that Mr. Bach spoke about. Same symptoms, but lasting for 2 years to be able to be diagnosed. There's also disruptive mood dysregulation disorder. And this is a form of a depressive disorder where you find that instead of being more along the spectrum of being very sad, you find that these are children who are very angry, you know, and at the core of it is depression. So you would find these children, their behavior characterized by extreme anger, irritability, frequent temper outbursts, and temper tantrums. Typically a child who's extremely moody and prone to aggressive behavior. All right, so some of the symptoms you would see basically almost every day. You're seeing irritable, angry mood, severe temper outbursts, trouble functioning in at home, at school, with peers. These symptoms must exist steadily for at least a year. All right, so to be diagnosed. And typically you would see it around age 10 or so. The onset, that is, it tends to manifest a little more significantly in that period of time. And then we have bipolar disorder, which exists also with children. All right, little less common with children as it is.
Yeah. Can I just interrupt? Are you hearing me?
Sure. Yes.
Yeah. What I wanted to ask now with the mood disorder, the mood dysregulation disorder, and even the ADHD, can anything in the home, parent behavior, that home context as risk factors, then can any of that trigger the condition? especially for those.
I want to say that they exist more as risk factors and as factors that exacerbate pre-existing vulnerabilities. All right. So I really don't want us to go down the line of establishing cause as well, right? So there may be things that are correlated or associated with it that really increase vulnerability. So if you live in a home, yes, with in a chaotic home or a violent home or a home where there's a lot of conflict, definitely a child who is predisposed to a condition like this may have an increased vulnerability to having more temper tantrums, more violent outbursts, things like that, right? If we're talking about family, the impact of family, we also know that a family history of depression or psychiatric history as well also lends itself to increasing the vulnerability of a child towards this condition as well. So definitely, yes, as a risk factor, factors within the family can influence both from a biological perspective as well as from an environmental perspective.
Yes, good. And I just wanted to bring that out because many times parents would come and say, well, look, I have 5 children. Why this one? Everybody's exposed. So I just wanted that to come out in the sense that from the viewer, from their point of view, thinking, well, what happened to this one? So even if it may be chaotic, maybe the home is chaotic, but then why is this one going down this mental health path?
Yeah, and if we talk about the genetic and the physiological basis of some of these disorders, we understand that there is a basis where there are certain neurotransmitters or brain chemicals which are secreted and may place someone more at risk of developing the disorder. But it does not mean that they absolutely will, but there are certain things in the environment that can really bring it to the fore, So sometimes it's important, yes, to understand that as well. To understand that, yes, we do have that physiological basis, but the environment and that whole nature-nurture debate really does come to play, especially when we talk about children who are very impressionable and, as I said, their development is evolving.
Okay, wonderful.
So those are some of the very common depressive disorders that I mentioned. I know we're short on time to be able to go through all, but really important, I think, for everybody to understand, particularly major depressive disorder. And as we talk about the disruptive and impulse control later on, it really ties in as well with the dysregulation disorder that I mentioned.
Wonderful, excellent. So what is one other area maybe, because we want to really get into that social aspect now, the family, the system, when they go into the system, what happens, what's available, things like that. So we could probably do phobia as our last. What would you, between Vandana, you and Mr. Batch, what would you choose as our last, maybe most common that maybe families going through and they need to hear about?
We could look at the anxiety disorders.
Okay.
I mean, basically, if you look at the whole DSM, you will find that someone is experiencing symptoms or maybe have a disorder within that. But again, because of time, we can't go through the entire DSM now. Yes. But basically, the anxiety disorders.
Sorry to interrupt here. Sorry to interrupt. Viewer, the DSM is the manual we use to get the criteria for all these disorders. Okay, it's the diagnostic and statistical manual. Okay, go ahead.
Right. So I could touch briefly on a couple of the anxiety disorders. Since I have an interest on phobias, I'll go with specific phobia. So specific phobia is basically marked intense fear and anxiety that individual has towards a particular object or situation, as well as a certain animal, or fear of blood, or even the fear of having an injection. The criteria for having a specific phobia is that, before I go on, this fear and anxiety that I'm speaking about, when it comes to children, they will exhibit this fear and this anxiety through freezing up or clinging, crying, or throwing tantrums. So this is how a child will exhibit these intense fear and anxiety that an adult would exhibit. So the criteria for specific phobia primarily is that the situation or the object immediately triggers or provokes intense fear and anxiety to the individual. The situation or the object, and when I say situation or object, I'm also talking about, let's say, animal phobia that a person may have, or a blood phobia. So, you know, there are people who could see blood and just faint automatically. There are those who have intense fear of needles, so avoid a doctor simply because of that fear of getting an injection. So these objects and situations provoke immediate intense fear and anxiety. Another thing is that the intense fear and anxiety that they usually display is often out of proportion to the actual situation or object in front of them. So, for example, somebody may see something as small as a cockroach and show the biggest tantrum. You know, so having this fear and anxiety, you will throw the tantrum, yes, but somebody else, they will look at the cockroach, pick up their slipper and just hit it a lash, and that's it. So the intense fear and anxiety is usually out of proportion to the actual object or situation. Another criteria, and this specific phobia is a timed phobia, a time frame. So the time frame for this is 6 months. The intense fear and anxiety must be consistent at a 6 months or more period. The phobias also is avoided at all costs. So like I said, an individual will avoid going to the doctor. You could be the sickest person on earth and you will avoid that doctor simply because of that fear of getting an injection, that fear of needles. So the object and the situation is avoided at all costs. And finally, these phobias cause clinical significant impairment in a person's life. For example, let's say a typical adventure of hiking, which a lot of people enjoy. Some people may tend to avoid hiking altogether because they don't know what animal is in those bushes. So I would avoid that just to avoid those animals. You have a question? Oh, okay.
I was just agreeing to that. That's me. Yes.
Oh, right. So, right. So they, it causes clinical significant impairment in their life. Moving along from specific phobia, there's one called social anxiety disorder, also known as social phobia. The criteria for social anxiety disorder is the same as that of specific phobia. The only difference is the definition. So this is intense fear and anxiety in relation to social situations. So let's say eating in a food court with people. Someone with social anxiety will avoid that altogether. Presenting in front of a class, doing presentations, that will trigger intense fear and anxiety in that individual as well. So the time frame of 6 months remains the same. The out of proportion to the actual situation is the same. Causing clinical significant impairment is the same, because now in society, in tertiary education in particular, you have to do a lot of group work and group presentations, which will then in turn allow you to present in front of your class. Some people will prefer to take a 0, bring the whole group down, than to actually perform or present in front of that class. So it does cause clinical significant impairment as well. And of course, the situation causes and provokes immediate intense fear and anxiety towards that individual.
Yeah,
right?
can I just add that around SAA time, that just emerges big time. I personally have seen that really come to the forefront around that time, both in the run up to and the going into secondary education, both for the social context itself and also the change in the presentation modes in the classroom. you know, you leave primary and then you end up in secondary, having to do presentations, stand up in front of the class and do at a different level. So that particular aspect is very prevalent around that time. Just wanted to add that.
Right. Looking at moving along, there is generalized anxiety disorder. So I'll touch on that one. Generalized anxiety is that fear and anxiety that individual has that they have difficulty controlling. So that worrying or that anxiety that individual have, they find it difficult to control that worrying. Now, there are 6 criteria to be met, or 6 criteria. For adults, you have to meet 3 of these 6. For children, you just have to meet 1. And the criteria is restlessness, first and foremost. So this is individuals who are restless all the time. They are experiencing restlessness. Then there is irritability. So individuals who are easily irritable, who will get angry easily. There is a lack of attention and concentration. So people with generalized anxiety disorder find it difficult to concentrate or to be focused. There is a sleep disturbance. So individuals with this disorder find it difficult to sleep. Then there is muscle tension. Again, individuals with this disorder, they suffer from muscle tension. And finally, there is fatigue. So out of these 6 symptoms that I just called out, an adult only needs 3 of those 6 to be diagnosed with generalized anxiety disorder. But a child just needs 1. The time frame is the same as the phobias, a period of 6 months or more.
Okay. Awesome. And that's sleep. I just wanted to bring out the point of sleep. We have a whole nation not sleeping properly. You know what I'm saying? So that is one of the first things I address and I ask about the sleep. And, you know, sometimes if you try to regulate sleep, that person comes back so much different in terms of, you know, you being able to see what you're really looking at. And that's awesome. Now, before we switch, Leo, can I ask you, in terms of PTSD, I know that we don't have much time, post-traumatic stress disorder. I know a lot of trauma symptoms are being misdiagnosed. Yeah. Leo, can you give us a word or two on that before we get into sort of we want our viewer to know about what is available and stuff and the system when it comes to mental health in Trinidad and Tobago. So we want to leave some time for that for sure. But we just wanted to touch on PTSD and trauma. Leo, can you share with us? Is Leo on? Yeah? Okay. Vandana, would you like to say a brief word on it?
Sure. Yeah, this is such an important topic because, you know, we live in a very traumatized society. I'm sorry to say. That is indeed the truth with regard to the status of a crime and so on. So we have a lot of children who have been exposed to adverse childhood experiences and very, very traumatic circumstances. So with PTSD, again, this is a condition under trauma and stressor-related disorders in the manual that Mr. Baksh was referring to. And with this, we have where children may present with intrusive thoughts or memories of the event. Now, they can either be a victim themselves of the traumatic incident or have heard about it or, you know, experienced it through someone else, you know. So some of these symptoms would be where they experience intrusive thoughts or memories of the event, meaning they keep thinking back, it keeps popping back in their memory, right? And then it's an unwanted memory. They don't want to think about it. It's upsetting dreams, nightmares, getting flashbacks of the incident, feeling very jumpy, startled, nervous about anything that triggers memories of the event. They may also actively avoid any reminders of the traumatic event as well. So they may not want to talk about it, they don't want to think about it. and they don't want to go to places or see people that remind them of what happened. You may find that they also exhibit some of the symptoms that we talked about in line with depression and anxiety. So they may have a lot of lasting worries and beliefs about the world being unsafe. They may blame themselves. They may have self-esteem challenges, lack of interest in some of the things that they previously enjoyed, feelings of anger, shame, sadness, guilt, even about what might have happened, even though they themselves are not to be blamed. Trauma manifesting itself in terms of sleep problems, eating challenges, mood challenges, and so. So you may also find that with children, you notice regressive behaviors, meaning that milestones that they would have achieved before, they suddenly have regressed to an earlier state. So a child may begin, an older child might begin to thumb suck again, or they may be wetting the bed again, or you may even find that they reenact the traumatic event through play, right? So play is a child's external world. This is how they make sense of the world. So you may see children actually demonstrating in their play the traumatic incident that they experienced. Usually symptoms begin within the first month after trauma, but sometimes they don't even show up that soon. It may take many months, sometimes even years to manifest itself, and the symptoms can continue for years to come. They may ease up and return later in life, and so especially sometimes around anniversaries of the event or when you have specific reminders being in the space and so. And it's very, very, very important to be able to receive intervention, to be able to treat with the traumatic incident, which is at the root of the depression and the anxiety and the anger and so.
Yes, wonderful, wonderful. Thank you, Vandana. And really and truly, trauma and PTSD, you know, is something that we cannot ignore when it comes to looking at the full spectrum of mental for children, okay, and adults as well. So can I hand back over to you, Hafiz, and you can sort of lead the discussion on what, you know, social and family concerns, etc.
All right, I think what we want to look at, we have covered so many, and we still have more to cover, but the time is going. But I just want to give the viewers, if they are able to diagnose or remember all those conditions, to be able to look at the children and remember all those things and decide that they probably need some additional assistance, where do we go? What are the first, second, third steps? Where do we go to get that help? Who are the first person to go? Do we find, right, I saw Vandana on TV, I saw Ali on TV. Let me see if I can find his number. Is that the first step, or do they go to a normal general practitioner?
Well, first of all, if you observe some of those signs, what you can do, you can go to a normal general practitioner who will then refer you to a mental health clinic, or what you can do as well, you can go to your local health center. You can go to the nearest accident and emergency, explain what is going on with the child, and then they will give you a referral letter to the nearest mental health clinic. So for example, there are specific mental health clinics for children. There's the Child Guidance Unit. There is one in San Fernando in Pleasantville, and there's one in Port of Spain. So there are only two child guidance clinics throughout the country, but for adults, there are many other psychiatric clinics out there. So that is in terms of one way they can get help, so they can go to the general practitioner who will refer them, or they can go straight to the health center or to the nearest accident and emergency, who will then give them guidance to the nearest mental health clinic.
So most people will have easy access to the health center. The health center does have that facility where they will be able to talk to them and then give them a referral to where they need to go.
Yes, most definitely. So they would, so how it works is that they would go to the health center, they may speak to a doctor there, and they would explain to the doctor what is going on, and the doctor would write a referral letter and tell them, I think this is what is happening to the child. So let's say ADHD, And then the child now, they will give you the referral letter. They will even write, some of them will give you the numbers of the clinic where you can call and make an appointment for the child.
And currently, what kind of waiting time for that particular clinic? You would probably be familiar with that?
Well, I can't really say because different clinics run differently in terms of the waiting time. So I can't really make a comment on the waiting time, but I know the clinics are designed to help people as soon as possible. So it really, if it's a very, very severe situation with the child, they will see the child probably as you walk in, if it's severe. If it's something that can wait, you may have like a 2 weeks waiting period also.
Are we aware of any NGOs that help children or help parents who need help in this particular area?
There are many, there are NGOs that provide mental health services. I know the Life Empowerment Center provides services. The Families in Action, they have mental health services as well. My colleagues could help me out here because those are the two I know for sure.
I'm aware that Parenting TT is also an NGO that does a lot of work with children as well as parents presenting with mental health challenges. This is not an NGO, it's a government agency as well, but the National Family Services Division also provides counseling services and other mental health interventions, mainly for adults, right? But when we talk about children as well, I know they won't refuse a child, but they may do some level of screening and refer the child as well. There's also, if the child has a child protection concern that goes along with a mental health concern that requires an investigation, and so there's also the Children's Authority of Trinidad and Tobago, where matters of traumatic concerns and child protection concerns, meaning, you have a concern that a child has been abused or neglected in some way, and therefore may be presenting with certain mental health symptoms. They can also be sent to the Children's Authority where they will get certain services. So those are in the government sector. We've talked about NGOs, we've talked about public sector, but there's also a big private sector for those persons that can afford these services. They may also seek those services privately. You may start, for example, at your general practitioner, your family physician, as Akeem was saying, who may then give you a referral to get those services privately if you so wish, right? So there are psychologists and counselors who may be able to work with children, and there are specialists as well. So persons who are trained with children may specialize in play therapy, art therapy, and so that you can also access those services. There's a website online that persons can check to be able to look for child therapists in Trinidad and Tobago. The Association of Psychologists of Trinidad and Tobago also has some contact information of persons who may be working with children as well, and that can be consulted.
Can you guys hear me?
Also, yes, go ahead, Leo.
Right. Let me also add to that the Ministry of Health has actually launched a database website, Find Care TT, that you can actually find any and all mental health services that are required, both public, private, and NGOs as well, on that website. So if you're seeking any sort of services for children, if you just type in the word children in the search box, it will bring up a list of all the organizations that provide mental health services geared towards children, including hotlines as well.
All right, so that's excellent information. And don't forget, if you have any problem, you could also call FISCAL, and they would be able to direct you accordingly. And again, we have this program, and you could go back to this program at any time. It will always be on, and go through this, and you will know where you could get help. Anybody else have any other advice in terms of how to go about getting the help?
Yeah, another important one that we fail to make mention of is actually student support services within the Ministry of Health. So they are doing both therapy and assessments for children. And well, with Ministry of Education, there are districts throughout the country. So there's the East, the South, there's the one in Port of Spain at head office. So student support services is also a medium that they could use.
All right, so we have 4 minutes again. Anybody have any last words? You start from, go ahead, Ali, you could give your last comments.
We live in a world where mental illness and mental health is a big thing now. 50 years ago, you ask your grandparents, what is depression? You'll quicker get a broomstick than an answer. But now we are in a society where there is quite a high percentage of students, children, and adults who are being diagnosed with depression, with anxiety, with a lot of the disorders. Some people are going about day-to-day activities and they don't even know they have a disorder. So a lot of people are also not diagnosed. And then there are some who are overly diagnosed. The thing is, if you have a disorder or a diagnosis, or if you are having symptoms, or if you just feel sad, the first thing I want to say is open up, speak out. Don't keep any of this bottled in, because you will be doing a lot more harm to yourself. And straying away from the point, I want to pinpoint specifically men, because we are socialized as being tough, not to cry, being brave. But men have we have emotions. Men have emotions. And now we are living in a society where I would say, from a professional point of view, speak up rather than mask it and be brave. Because aside from depression and the neurodevelopmental disorders and anxiety, what we are seeing a big increase in is suicidal thoughts and suicidal attempts. And if you look at the statistics, and I could be off, but from what I last read, it's a lot of men that are doing the suicidal act, right? So my advice to everyone, men, women, children, speak out. If you have a mental problem, or if you feeling sad, or if you just need someone to talk to, speak out. Yeah, there is a lot of stigma still attached to mental health, but at the end of the day, you want to be better. You want to feel better. You don't want to be bombarded with negative thoughts or suicidal thoughts or, all sorts of external and internal stressors affecting you. You want to be better. You want to smile again. So speak out as one of the first steps in getting better.
All right, great advice. Akeem, last words?
Right. My last words would be, I encourage, piggybacking on what Ali said, I really encourage people to speak out, seek help. And it is okay to seek help. It is okay to go to a mental health clinic. It is okay to tell your friends, I am not well, this is what is happening to me. And they will advise you accordingly. They would say something and something right. I think you should seek help. I think you should seek professional help. So I encourage people just to seek help, speak out, and stop discriminating or stigmatizing people who suffer from a mental illness. That is something we need to work on. We need to stop. And the only how we can work on that is by changing our language, the way we speak. So I would urge people to just think about what you say about people who suffer from a mental illness. So we may see somebody walking down the road, he mad, avoid using those terms. That's all.
Leo,
thank you so much.
Are you back on? Last comments?
I want to take one follow-up to what Akeem just said. We have culturally associated that word mad with mental health. Multiple calypsos, kaisos, and songs mention the term mad is an emotion, mad is anger, mad does not equate to poor mental health. And quite frankly, we all exist on the spectrum. One too many bad days is the difference between us being what we would describe as normal and us being very similar to the people that we are claiming are mad. We take good care of our physical health, we take vitamins, we exercise, and it is high time that we start doing the same with mental health. Exercise, as everybody said, ask for help. That's something that we have not been brought up to do, especially as men. No offense to the ladies, but we have been taught that if you can't do it on your own, you're weak. No, it's the reverse actually. Being willing to ask for help is a sign of strength, and do not hesitate at all.
Vandana?
Yeah, Leo hit the nail on the head there. With physical illness, you know, if you've lost a leg or you're losing a leg, we don't sit there and let the leg rot away, right? You go to the hospital, you get the necessary services. If you're diagnosed with a particular physical illness, you don't hesitate, well, most people don't hesitate to seek physical help. You take your medication, you know, you do whatever surgical procedure might be needed to fix the problem. Mental illness is no different. If you are mentally unwell, there needs to be a similar level of commitment to seeking intervention and seeking help. And when we say help, what do we mean? It does not have to mean that you're going to be taking medication and looking like a zombie, as some people might think. You know, sometimes it's simply talking to someone else and being able to ventilate what you're going through and finding that support. So a lot of people think, how could just talking help? It really does help, you know, because you find an avenue to be able to express all those things that you bottled up inside. And sometimes you find the words you didn't even know you had, just by being able to speak to a person who's trained to be able to direct the conversation in a productive manner to bring out those thoughts and those feelings. And as we talk about children, I just really want to say that this is the opportunity that we have when we have children to be able to socialize our children in a manner that allows them to be mentally healthy and to be able to treat others in a way that create a mentally healthy society. So I really want us to underscore the importance of children's mental health, their own, and raising them in a way that helps them to nurture others in a way that creates mentally healthy individuals.
Michelle, your last thoughts?
I'm just pleased. I want to thank the panelists. I'm pleased with all the excellent quality information that was shared. Very relatable as well. So I just want to encourage you viewers to use what we have given you to take positive action and stay tuned. We have 2 more weeks to go. Stay with us. Okay, back to you, please.
All right, and I would like to start with thanking all the panelists and Michelle also for the great work that they have done. They have thrown a lot at the viewers, and the viewers, I would like to ask them to go and look at this program as much as possible, many times, and then you will start making sense out of it, because it has been quite a lot of information that has been thrown at you, but it is vital information that you now have, so you could build on that awareness by going over and over again and listening to this program. It's there on Facebook for you to look as much as possible. Our next program would be next week, Sunday, and we'll be looking at the 12 to 18, and we'll probably be going through a lot of the same thing that we have, so it will make it interesting. Your comments and questions would be helpful in determining whether we need to have an extension of this particular program, because there were a lot of things that were not covered. And if you all are interested, give us the feedback so we could determine if we need to put another program on, so that we could really finish a comprehensive dealing with this particular issue. So once again, thank you all for joining us, and join us next week again. Have a good evening.